My name is Mary Lloyd Ireland. I practice at the University of Kentucky in Lexington, Kentucky. I'm going to present a couple of cases involving the thigh that aren't quite as straightforward as you might think. Localized myositis ossificans occurs after a direct blow. Usually it's a football helmet to the thigh. This should be treated with non-steroidal anti-inflammatory medicines. Indocin seems to work the best, trying to keep the quad muscle on stretch and doing no surgery. This can look like somewhat of an aggressive lesion histologically, but this is what this looks like at about a month after the original injury. The thigh in these cases is extremely tender on palpation and can be firm. This is what it looks like when the lesion is more mature and is healed, and basically we do nothing surgically with these lesions. They can be mistaken for a more aggressive tumor, such as an osteosarcoma, when they are looked at histologically. This is a case that I have treated. If you look at the way this is maturing, this is at 2 months after the original injury, this is at 4 months, and this is at 6 months. So again, do very little specifically to the muscle, no modalities, nothing to stir things up. Keep them on Indocin with warning that there could be some GI upset. Try to keep the muscle on stretch as much as possible, and this may take 6 months to resolve. You definitely don't want them to go back out and get hit again. Oftentimes there will be, in severe cases of a severe contusion, a sympathetic knee effusion. So treat that with trying to keep flexion range of motion. Next case is a 17-year-old high school junior. He was on kickoff, tackling somebody. The running back hit him with his head down, helmet to the thigh. He was knocked out. This patient presented 12 hours later with severe pain in his thigh. If you think about a compartment syndrome, particularly if there is pain out of proportion to what one would think, sometimes the other P's aren't clear and are not present. But if you have an athlete with a significant blow to their thigh, and kickoffs are very high energy. So this patient ended up with a thigh compartment syndrome. And this is after we've done his needle compression, which we did just with the anesthesia monitors. Pressures were in the 80s. Here is his compartment release. Fortunately, the muscle was very normal in appearance, very red, and I did close him primarily. This is his exam 3 months after his injury. He wanted to go back and play in the playoffs, his high school senior season. I told him that he should not do that. He did seek another opinion, and fortunately, the second opinion did not clear him to go back and play. So this individual did very well with his compartment release, having full range of motion of his knee and excellent thigh function. Fascia was left open, skin was closed primarily. I hope these cases will make you think about certain conditions that you may not have thought about before. Remember, you may not have seen it, but it has seen you.